Meeting is now streaming live.
How many slides, Srinivas?
60, sir.
Only. Okay, we're live.
Yes, sir.
Good afternoon, all. This is Dr. Niranjan Panigrahi from the site from Apollo Hospital, Hyderabad. Along with me, we have today's speaker Dr. Srinivas Satrasala, who is a consultant in the Department of Critical Care Medicine, Apollo Hospital, Jubilee Hills. Dr. Srinivas holds the portfolio of medical ICU, infectious disease ICU, and has a vast experience in neuro ICU and surgical ICUs. Now, his area of interest is the reading the image or imagology in critical care medicines. So today we will be going to listen the fundamentals of CT scan and MRI reading for our nurse practitioners in critical care medicine. Dr. Srinivas, so over to you. Please go through.
So thank you, sir, for the kind introduction. And I thank ISCCM for giving me this opportunity to participate at this level. Today, my topic would be fundamentals of CT scan and MRI, nurse perspective. Uh, So evolution of digital imaging in radiology has started in 1895 with the invent of X-ray, which was discovered by William Röntgen. Later in 1939, neutron beam was invented by John Lawrence, and he was regarded as the father of nuclear medicine. Later in 1942, ultrasound was used in medical practice. Later in 1971, CT scan was introduced by Godfrey Hounsfield for medical use. Later in 1977, first MRI was done on human subjects. So it took around 80 years from 1895, the introduction of X-ray to the CT scan and MRI. So it was a long journey for the development of CT scan and MRI. So now we after the
Sir,
discovery
sorry
of
to
CT
interrupt,
scan.
sir, but the screen sharing has stopped, sir. We cannot see your slides, sir.
Okay, 1 minute. Are you able to see? Should I start again?
Yes, yes.
Okay. In 1895, X-ray was introduced by William Röntgen. Later in 1939, uh, neutron beam was introduced by John Lawrence, and he was regarded as the father of nuclear medicine. Later in 1942, ultrasound was used for medical purposes. Later in 1971, CT scan was introduced by Godfrey Hounsfield, and in 1977, MRI was discovered. So it took around 80 years from 1995 for the discovery of the CT scan and the use of the MRI. Since 1971, where the MRI, where the CT scan was introduced, it has changed dramatically, and it has evolved into 5 generations. First generation had a pencil beam X-ray source, and the head is placed in a water bath. 1 to 2 detectors were present, and the scan time was 5 minutes. It was mainly used for the scanning of the brain. So you can see here that the patient head was introduced into a water bath so that the X-ray would not disappear. Disperse, and the detector would detect the X-rays and the films, and we will get an CT scan. Later, this was very cumbersome, so there was a fan-shaped beam source for the X-ray, and then there was the 50 to 30 detectors to detect the source from the head, from the tissue, and the scan time was 30 seconds. Later, third generation CT scan used fan-shaped beam source, and the rotation of the fan-shaped beam source was 30 to 60 degrees. The curvilinear detector array for constant detection of images was used, and the scan time was reduced to 1 second, and it has superior resolution. Later, fourth generation CT scan was introduced with the same fan beam shaped source, but the detectors were 8,000 and the scan time was 1 second. It has highest radiation dose and highest resolution. Later, fifth generation CT scan has come into medical use. We Most of the hospitals now have fifth generation CT scan, which is latest, and it can also have heart scan can be performed, and it has very high resolution, and it uses electron beam instead of X-ray, which was used in first to fourth generation. The extension of fifth generation CT scan is a spiral CT scan, which allows for continuous data acquisition, and tube rotates at 360 degrees. It had 14,600 detectors, and with the single scan we could get many multiple slices. So the common indication for non-contrast CT, why non-contrast CT? There are two types of CTs. There are contrast and non-contrast CT. Non-contrast is a plain CT, and the clinical scenarios where the non-contrast CT is preferred is in acute stroke patients who presented with the hospital within 3 hours, and when the stroke is detected, then contrast is used to see the CT angiogram of the neck and for the follow-up of the patient. When a case present with a closed head injury, CT is the first priority to evaluate the head injury and also the spinal injury. When a patient present with dyspnea, we suspect a diffuse lung injury or chronic dyspnea. Then HRCT, that is high resolution CT scan of the chest, is done without contrast. When there is an infection of the soft tissue with swelling and trauma, contrast is necessary to rule out any vascular involvement is present or not. When we suspect any kidney stones, we use renal stone protocol CT scans to see the position of the stone, and to and when a patient present with a spinal trauma, we do a CT scan of the cervical, thoracic, and lumbar spine to rule out any spinal injury. So now the common indication for contrast CT would be in case of acute appendicitis, we usually do an abdominal and pelvic CT scan with an oral and rectal contrast. When to stage the cancer also, we use some protocols like contrast enhanced CT scan for staging and typing. When we suspect diverticulitis, which could be a complication of inflammatory bowel disease, intravenous and oral contrast are used. When we suspect a pancreatitis, which is very common nowadays, we first we do a non-contrast CT scan to see for calcification whether these are responsible for the CT scan for the pancreatitis. Then we do a contrast enhanced CT to know whether the pancreas has evolved into a pancreatic pseudocyst, and the pulmonary embolism in we do a contrast enhanced CT to know the position of the embolus. So, contraindication of CT scan are hypersensitivity to iodinated contrast agent in pregnancy are the absolute contraindications, and the irregular rhythm, renal insufficiency, metallic interference would be the relative contraindications. This slide shows that what is the ionizing radiation which occurs when different types of radiological imaging are done. When we do an dental radiograph, brain takes 0.005 milligrays of ionizing radiation. When we do an posterior anterior chest radiograph, that is an chest X-ray, lung takes 0.01 milligrays of ionizing radiation. When we do a lateral chest radiography, that is lateral chest X-ray, the lung takes about 0.15 milligrays of ionizing radiation. But when we do a screening mammography, the breast takes 3 milligrays of ionizing radiation. Stomach takes around 10 milligrays of ionizing radiation when an abdominal CT is done, and colon takes around 15 milligrays when an barium enema is conducted, and neonatal abdominal CT gives around 20 milligrays of radiation to the stomach. So we can see that dental radiography is the least possible radiation which can occur to any part, and the abdominal CT has the highest ionizing radiation that can occur to stomach. So this is an MRI where you can see radio frequency coils, gradient coils, magnet and scanner, and the patient table and the patient. This is the schematic representation of the MRI, which is which is a very bit cumbersome to explain, but it is very complicated. So the basic principle of MRI would be it employs a powerful magnet which produces a strong magnetic field that forces protons in the body to align with that of the field. During this process, when a pulse is given to the patient, the protons are stimulated and they are spin out and gives images, and these images can be obtained in axial, sagittal, and coronal planes. So the common indication for MRI is during ischemia, sinus thrombosis, dissection, vascular malformation, temporal epilepsy, so on in the brain. So a brain MRI is done to rule in or rule out ischemia, sinus thrombosis, dissection, vascular malformations. Spinal cord MRI is done to rule in or rule out radiculopathies, myelopathies, infections, and tumors. Musculoskeletal MRI is done to inspect infections, tumors, and arthropathies. Abdominopelvic MRI is done to delineate hepatic or adrenal lesions, pancreatic pathologies, intestine, prostatic carcinomas, and cardiovascular MRI is done to check whether there is any ischemia, cardiomyopathies, intracardiac tumors, and mammography, that is breast MRI is done to know the extent of the tumor, and MRI during pregnancy is done to know whether there are any fetal abnormalities present or not. So as we have seen earlier, the MRA suit is very cumbersome, and it usually gives a claustrophobic effect because it has a very big passage in a big downward shape of thing. So most of the patients in the MRA can have claustrophobic effect, so and can have some hazards. So these hazards can be categorized into different categories. But when the patient has an implantable surgical devices in their body, they can get heated up because of the radio frequency coils, and the metals which are present in the body can give blurred images, and there can be thermoregulatory issues like heating and heat loss. The heating is because of the fast rotation of the radio frequency plates which are used for the MRI. And as the passage is very long and it is concealed, the monitoring could be difficult with minimal patient access. And and during patients who require anesthesia, MRI suit can become a nightmare to the anesthetist, because you cannot approach the patient easily, and you have to prepare the patient beforehand to take for the MRI. And when we give anesthesia with anesthetic agents, MRI chamber can also get polluted. So usually radiologists use sedation in the MRI suit to relax patient with anxiety or claustrophobia, to calm children so that they remain still, and technologists can take the right images to prevent or reduce pain and sensation. For interventional radiology procedures, to lessen discomfort, minimize the risk of complication, and reduce patient ability to sense and remember pain. So, what type of patients require anesthesia? These are children or adults with learning disorders, patient with severe movement disorders, patient with whose position is limited by pain, claustrophobic patients, ventilated patients, and neurosurgical patients, and patients having surgery with intraoperative MRI. So while conducting anesthesia in the MRI, it is very important to have these set of instruments present for the safety of the patient. These are plastic battery operated laryngoscope, medical gas cylinder made from aluminum, MR compatible pulse oximeter, invasive blood pressure monitoring if required, and non-invasive blood pressure monitoring, that is a must. And while putting the ECG leads, this type of schematic representation of the ECG would give correct reading rather than the scattered ECG placement. So while monitoring sedation during anesthesia, airway would usually be affected when you give general anesthesia and deep sedation. And spontaneous ventilation can be affected when general anesthesia and deep sedation are given, and cardiovascular function can be affected when general anesthesia and deep sedation given. So monitoring is at must with all the equipment which we have just discussed. And the contraindication to MRI scanner, pacemaker, defibrillator, or wires other than sternal wires, metallic foreign body in the eye, deep brain stimulators, Swan-Ganz catheters, cerebral aneurysm clips, cochlear implants, magnetic dental implants. So we have seen the indications and contraindication of CT and MRI. Now, when we compare both CT and MRI, MRI has the advantage of giving images with different contrast, and it has a superiority for detecting of the tumors with no side effects of any radiation and fewer side effects from the MRI contrast. The advantage of CT scan is it takes lesser time for screening, and it is good for the bone structures. It is cheaper than MRI, and it is widely available than MRI, and lesser stringent, remaining motionless. That is, the patient have to be in the CT scan for not less than for only for 1 to 2 minutes. So it is very comfortable for the patient to undergo the CT scan. But the disadvantage with CT scan is they uses ionizing radiation, and risk of allergic reaction to the contrast material could be present. And the disadvantage with MRI is the claustrophobic patient may need anesthesia. Some patients with surgical clips of metal fragments and the heart monitor or pacemaker may not be able to have an MRI, and it is not cost effective. And patient has to remain motionless for more than 30 minutes. So imaging of the chest. So when we do an CT scan of the chest, we get three types of images in three different planes. The first image, the one image is an transverse plane image or axial image, and the figure two represent the coronal plane, and the figure three represent the sagittal plane of the patient. And we have two types of CT scan, that is the standard CT scan and then HRCT. In HRCT means that is high resolution CT scan, we get thinner slice width than in the conventional CT scan, typically less than 1.5 mm compared to 5 to 10 mm with the conventional or the standard CT scan. If the images are taken continuously without any gap, the effective dose can be higher than for the conventional CT, and the HRCT provides higher resolution, better image quality than the conventional CT. Here you can see that the standard CT is a little blurred than the HRCT, and we can see the structures clearly in HRCT than in the standard CT. So now we will see three places which are at the level of trachea, at the main bronchus and the heart, and the structure which are seen at these places. When the slice we get is at the level of trachea, we find AN anterior, P is the posterior, and AP is the apical lobes of the lung, and APP is the apico posterior lobe of the lung. When the slice we get is at the level of the main bronchus, we can see the anterior upper lobes of the lungs and the superior lower lobes of the lung. But at the level of the heart, there are many multiple structures are present, but these are all represent the lower lobe of the lungs, where there are the superior lower lobe of the lungs, anterior lower lobes of the lungs, lateral middle lower lobes of the lungs, and posterior lower lobes of the lungs, along with the superior inferior lingula and middle and lateral middle lobes. And we get three types of windows with the CT scan of the chest. These are lung window, mediastinal window, and the brain window, and the bone window. Lung window is used to evaluate the lung parenchyma as well as adjacent blood vessels. Mediastinal window is an overexposed and simply appears black. This algorithm is used to assess chest wall and mediastinal structures, and bone window is used for evaluating the bone structures. This is an air bronchogram. Here you can see an hyperdense lesion with an hypodense violet structures. Hypodense means they are black in color. Hyperdense is white in color. So you see wires in an white color structure, which is very dense structure. So this black is formed by the air, and the white is formed by the tissue, which is not aerated or which is occupied with the pus. So this is an air bronchogram, which indicates that the patient is having pneumonia or consolidation or hyaline membrane disease. So these two are batwing sign and then reverse batwing sign. This batwing sign is due to pulmonary edema, pneumonia, aspiration pneumonia, pneumocystic pneumonia, or viral pneumonias, and usually we see in inhalational injuries like noxious gases. The reverse batwing sign is this. The B represent the reverse batwing sign, where the peripheries are sprayed a little bit, not like the adjacent slide, and it's called reverse batwing sign, where it is seen in the organizing pneumonias, bronchoalveolar carcinomas, pulmonary contusion, pulmonary hemorrhages, and the pulmonary vasculititis. This is a classical representation of TB patient who is having scattered TB in the lungs, which is called as miliary tuberculosis. This is these two, the air crescent sign and the halo sign, which we can see here, are the characteristic features of aspergillosis, where the air crescent sign appears as an irregular shaped cavity in the right apical zone with an oval shaped mass within it. This is the air crescent sign, and this is an halo sign, where a solid nodule is surrounded by the halo of ground glass opacification. This is a ground glass opacification. Many of us have seen many number of times in the recent endemic of recent epidemic of the COVID, where these type of CT scan we were seeing for 10 to 15 times in one day with a lot of patients. So we will elaborate on this ground glass opacification with regards to the COVID. So in the early COVID, these three CT slices represented the early COVID or the mild COVID, where you have an single or multiple scattered patchy ground glass opacification predominantly distributed in the peripheries, not in the center, and in the subpleural area of the lung. Where when there is an moderate COVID, that is the downslide, which shows a moderate COVID with increased extent and density of the bilateral lung parenchymal opacities, and when this moderate COVID turns into a severe COVID, it represents as an diffuse consolidation of lung parenchyma with uneven densities, air bronchogram, bronchial dilation, everything will lead into an whiteout lung, and this is a severe form of the COVID or severe form of the ground glass opacification. This is crazy pattern, which is usually seen in pneumocystic carni, mucinous bronchoalveolar carcinoma, non-specific industrial pneumonia, or organizing pneumonia. This is the honeycomb appearance of the patient. Usually, these are seen in the pulmonary UIP, that is usually interstitial pneumonia. Previously, it was considered as a chronic disease leading to the honeycombing, and so this interstitial pneumonia is an permanent fibrotic change of the lung and reflects the end stage parenchymal destruction. That is a chronic patient with interstitial pneumonia leading into honeycombing type of structures. And these can also be seen with hypersensitive pneumonitis, asbestosis, and sarcoidosis. So this is a green arrow which shows the pneumothorax. This is the anterior part of the chest. This is the posterior part of the chest. Air, when it gets into the pleural space, it goes to the above anteriorly, that is upper part of the chest, and here you can see the dark area or the hyperlucent structure, which is due to air. When the CT scan is performed, the air just the x-rays just pass through that air and will give an black shape structure. So whenever you see a black shape structure, then you have to think of the pneumothorax, and it usually in the apical surface or anterior to the chest wall. When you see such type of structure like a sand structure in the subcutaneous planes, then you have to suspect subcutaneous emphysema, that is air in the subcutaneous tissues. So what is pleural effusion? Here you can see um, uh, light gray and dark gray structures. The light gray structure is usually due to collapsed lung, and these dark gray structures are because of the fluid filled structures. When the CT scan is done, the rays from the CT scan cannot penetrate powerfully into the uh, they can penetrate more easily through the water than through the lung. So the water appears a bit darker than the lung. So here you can see that the lung is can be differentiated from the pleural spaces, which is filled with the pleural effusion. Yeah, this is the CT slice of an congestive heart failure. It The congestive heart failure is due to the increase in the hydrostatic pressure, causing the fluid into the lungs, and it can be seen as a groundless opacification, bronchovascular bundle thickening, interlobar septal thickening, or pleural effusions. So till now we have seen non-contrast CT scans and the indication for the contrast CT scan would be an pulmonary embolism. Here the contrast CT scan of the chest is done to visualize the pathologies of the pulmonary vasculature. In this contrast, CT scan of the chest shows filling defects in the right pulmonary artery, which suggests an pulmonary embolism. Now we will go into the imaging of the abdomen. So CT scan of the abdomen can be done, and the MRI of the abdomen can be done. MRI of the abdomen doesn't have any radiation. It is very slow to perform. That means it takes around 20 to 30 minutes to get performed. It is used for characterization of the lesions, and it has best tissue resolutions but it is not useful for any calcification. It is excellent for the pelvic organs, and gadolinium based IV contrast is usually used. When a CT abdomen is done, it takes less than 5 minutes, and it has radiation. It is good for solid organs, fat planes, and it has best spatial resolution, and it is excellent for the calcification, and it uses ionized iodine based intravenous contrast. Here this is an CT scan of the abdomen. This is the normal pancreas. You can see here, this is an acute pancreatitis. How we know that this is an acute pancreatitis? It is the structure of the pancreas is usually delineated. That means the borders of the pancreas are well preserved in a normal pancreas, but in an acute pancreatitis, the borders are not properly seen, and it is very scattered, and it is also enlarged, and it is very edematous, um, and the diameter is more than the diameter of the aortic diameter, which increase that the size has increased, the pancreatic size has increased. This C represent the colon, ST represent the stomach, and the P represent the pancreas. This is a normal CT scan of of a normal patient who presented with the stool impaction. Here you can see the colon, small bowels, and the large bowels, which is a part of the large bowel, is identified by the saculations called hostrations. These are the hostrations here. You can see the colon has fat-filled tags called appendices, epilopecae on its surface. These hostra and epiploicae separate the large from the small intestine. Colon is here you can see that the colon is filled with the feces. The small bowel is located in the center of the abdomen. Whenever the small bowel is located in the center of the abdomen, it is usually normal, and it is normal place to have the small bowel in the center. These are some examples of pathology that can be detected with an CT scan with the contrast. This first figure, A figure, represent an upper abdominal CT with oral and intravenous contrast. The vascular contrast lightens the liver parenchyma to better visualize the liver metastasis. That means you can see that the lesions appear dark in color and the normal liver appears light in color, light gray in color. Like this, we can know that whether the liver has any problems or not. Uh, the slide B shows CT with oral and IV contrast showing the large and enlarged retroperitoneal lymph nodes. Usually, the center should be present with the small bowels, but here these are large lymph nodes, or the we will call them as lymphadenopathy. The slide C shows an oral and IV contrast of patient with calcified gallstones. Has the gallstone, which is a stone which doesn't take up the contrast, it usually is represented as a very bright structure. And so, whenever you see a very bright structure near the liver and below the and adjacent to the gallbladder, then you should suspect an gallstones. And this is an CT with IV contrast that demonstrates small bowel obstruction. This is the dilated small bowels. Now we will go into the imaging of the brain. Patient, while doing an CT scan of the brain, the patient is usually kept in supine position and the tube rotates around the patient in the gantry to prevent unnecessary irradiation of the orbits. Head CTs are performed at an angle parallel to the base of the skull. The slice thickness could be 5 to 10 mm for a routine head CT, and here it is the CECT, that means a contrast enhanced CT scan of a patient representing different nodules over here. This could be a mass, and we have to examine, or we have to investigate more to know what is the structure of these masses. When we do an CT scan of the head, we get axial CT scan of the head, sagittal, and the coronal sections. And also we get soft tissue windows and bone windows. The soft tissue windows is used to evaluate the brain parenchyma, hemorrhage, CSF spaces, and soft tissue tumors. Bone window is used for identifying the fractures. All the structures which are very black in color is water, or the house fill unit is zero. That means the ionizing radiation which passes through the head will pass very freely and gives an Hounsfield radiation of the Hounsfield radiation of zero. And if air is present, it is more freely accessible to the X-ray beam. So it has an Hounsfield unit of minus 1000, and the bone which doesn't allow any penetration of the ionizing radiation has an Hounsfield unit of 1000. That means whenever the beam is obstructed by an powerful structure like bone, then you get an bright structure, and it has an Hounsfield unit of 1000, and which freely allows the ionizing beam is air, which has an Hounsfield unit of minus 1000, and CSF, which is neutral, it has an Hounsfield unit of 0, and all other structures are equated with the CSF Hounsfield unit of 0. While reading an CT scan, I usually prefer the mnemonic. Blood can be very bad. That means I usually prefer to see whether the blood is present in the CT scan initially. Then I will look for the cisterns, then the brain parenchyma, then ventricles, and then the bones. When we get a CT scan, usually we see lot of images, and it is very difficult to know which image is what if we don't have any systematic approach for this reading of the CT scan. So to read CT scan easily, 6 essential sections of the brain are preferred as we go from the base of the skull. This is the base of the skull to the top. To remember this, I usually remember them as a X, star, Mr. Happy, Mr. Sad, warm shape, and the bean shape structures. As we go further, I will explain you how these are, how I remembered, and how these are can be remembered. Whenever you see an X-shaped structure on the CT scan, see here an X-shaped structure on the CT scan, it is the first section that is taken at the base of the skull. Here you see the globe, temporal lobes, brainstem, and cerebellum. The base of the skull forms the X shape. As we go further, we see supracellular levels. We are at the supracellular level, where it appears as a star-shaped structure having basilar artery within it, surrounded by right and left temporal lobe pons and medulla at the base. Here you can see the left and right temporal lobes, the frontal lobes, the fourth ventricle, and the basilar artery. So here this represent an star shaped structure. So whenever you see a star shape like this structure, you are at the basilar artery level, and here you can visualize the any pathologies of the cerebellum properly. When we go up little more further, we see the flax cerebri, that is the flax cerebri which is in the center, and the lateral ventricles which are besides this flax cerebri, and the third ventricle is the third ventricle, and adjacent to the third ventricle, there are the thalamic and occipital lobes and the calcified pineal glands. These are the calcified pineal gland. This is not abnormal. This is normal. This is normal pineal glands, and these are calcified. And calcified the choroid plexus, which appear bright in color. This Mr. phase because of the shape of the quadrigeminal. These are the quadrigeminal cisterns and the anterior horns of the lateral ventricle, looking like a face of the face of a person who is happy. See, here is the quadrigeminal cisterns, and these are the lateral ventricles. When we put them together, we find an Mr. Happy face-like structure, and this place is one of the best place to identify the deep parenchymal bleeds and sometimes the hydrocephalus. As we move up further, we are at the occipital horn, at the level of occipital horns of the lateral ventricles, along with the frontal horns of the lateral ventricles, taking the shape of the Mr. Sad, the sorrow face. And as we move up little further, we see worm shaped like structures. These are formed because of the body of the lateral ventricles and the body of the lateral ventricles, choroid plexus, and the middle structure is the flax cerebri, and the below structures would be occipital lobes, and the middle structures is the temporal lobes. This is the sylvian lobe. This is the best place to identify any bleeds in the interventricular system. Here you can see that there are bleeds in the interventricular system because of gravity. The bleed has come to this place. So this is one of the best places to see whether the ventricles are having any bleeding in it. As we move up a little further, we see. Two parts of the cerebrum looking like the two beans and the flax cerebri at the top and sebaceous as a sinus at the below. It represents as a coffee bean structures. And in this slice of the CT scan, you can see that this is an SDH. When the blood is present in the CT scan, it represents as a bright structure. But when the blood in the CT scan has been there for much time, it becomes dark in color. So here you can see this is a chronic SDH and this is an acute SDH. Why this acute SDH? Because of the brightness, that is the hyperdense lesion, and this is an hypodense lesion. Now we will move to the MRIs of the brain. When we order an MRI of the brain, you usually get T1 weighted sequence, T2 weighted sequence, FLAIR, DWI, and ADC, and GRE, MRA, and MRV. This T1 weighted image is an MRI enhanced the signal of the fatty tissue and suppress the signal of the water. So here the signal of the water is suppressed, uh, the fat tissue is enhanced, and T2 is reverse of the T1, where the enhancement of the water is present. We will look deep into the T1 weighted image, T2 weighted image, FLAIR, DWI, and ADC in our further slides. This is a T1 weighted image where the white matter appears gray white, and the gray matter appears dark, gray dark, and CSF appears dark. Remember that a T1 weighted image is usually look for an any anatomical structure. That means congenitally some people will have some abnormalities. So you have to check T1 weighted image to know whether there is any structural abnormality is present initially before you reading an CT, you read an MRI or not. T2 weighted image is very important image where you just remember that the CSF is white in color and edema is gray white in color, and T2 is considered the pathological image, and most pathologists increase the fluid content of tissue and shows up as a high sickness including the surrounding edema. Here you can see that there is an edema, that means there could be an infarct here, and this infarct has caused edema, so there is bright structure in this T2 weighted image. Whenever you suspect an infarct, we usually prefer diffusion weighted image. This diffusion weighted image is due to the movements of water through the tissue. This diffusion weighted image is used to know acute stroke identification. So, this is very important to identify the stroke patient whether the stroke is been acute or not. That is, acute means within 1 hour or not, and within 3 hours or not, we can identify by examining the hyperdense lesions on the diffusion weighted image. So whenever you find an hyperdense lesion on a diffusion weighted image, think that it is an acute stroke, and this is a gold standard for infarct core estimation. It is very sensitive early in the evolution of the ischemia. Infarction edema, that means after infarction there will be edema, and so this edema represent as an white structure, that is hyperdense. So here you can see edema which is because of the infarction. Only acute infarction edema has water diffusion restriction and it is bright in color. So this area is infarcted, so the water movement is not present. Whenever the water movement is not present, you will find an a hyperdense lesion. So by this you will know that the tissue is dead or it is ischemic. The flare is one of the other important sequences. Here the edema looks gray white as T2 weighted image, and the chronic infarct appears as gray white, and CSF usually suppressed on the flare. Most pathologies exhibit bright on the flare like than SAH. So ADC is usually done along with the diffusion weighted image. So here you can see in diffusion weighted image, because of the infarction, because of the decreased movement of the water, there is an hyperdense lesion. So this should be compared with the ADC, which shows an hypodense lesion. So this is an opposite of the ADC. So usually we do an ADC to know whether the infarct size is the same as we are seeing in the diffusion weighted image, or there is some area which is compromised and which can be reperfused through our thrombolysis or mechanical thrombectomy, that is the penumbra. So to know whether the penumbra is present or not, we do an ADC and we compare with the diffusion weighted image, and we will take a decision whether we should go for thrombolysis or mechanical thrombectomy. So ADC infarction edema is dark. ADC reflects the water diffusion coefficient. Cytotoxic edema is dark. So you can see the dark structure over here. This is an infarction and edema. So susceptibility weighted image is this one. It is used in detecting the hemorrhagic transformation of the infarction. So now we will go into some cases. A 68-year female with right hemiplegia presented after 6 hours to the ER. CT image was done. Usually, whenever a patient with hemiplegia, we do an CT scan to know whether there is any bleed or not. So, CT scan is usually done always to know whether there is an bleeding or not. But it is not usually done to know whether the patient has infarct or not. So, always CT is done to know hemorrhage or any hemorrhage is present or there or not. So here, when the CT scan is done for this patient, you see an hyperdense lesions in the sylvium, in the fissures. This is an hyperdense MCA sign. It is because of the thrombus of the MCA artery. And in this 2 and 3, you can see the color change from the surrounding structures. And here you can see that there is less demarcation from this side. This is the demarcation is blurred here. The demarcation of the white matter and gray matter is good. So whenever you see an last demarcation, then you have to suspect an infarct. So we will see a patient of 58-year-old male smoker and hypertensive present with sudden onset of right hemiparesis and dysphonia. MRI was done, CT was done, there was no bleed, then MRI was performed. Here you can see in the diffusion weighted image, which is the most sensitive imaging modality for knowing the ischemia. So as we have said earlier, when there is ischemia, the water movement in that dead tissue will not move like the water in the normal tissue. In normal tissue, water moves from one cell to other cell, but in dead tissue, water doesn't move. So because of the decreased water movement, when MRI is done, it looks brighter, and by this we will know that the patient had acute infarction. And we do an MRA. MRA is magnetic resonant angiography. That is angiography to know the culprit vessel which has led into the ischemia. Now we will see the bleeds. So the gold standard for knowing the bleed is an CT scan. Here you can see two types of images. These both represent EDH. EDH is usually represent as a lens. We usually have seen lenses. The EDH is because of the accumulation of blood in the epidural spaces, which represent as an lens strip structure. It is usually because of the middle meningeal artery tear, and this extradural hematoma, it doesn't cross the suture line. This is the suture line. Whenever any bleed doesn't cross the suture line, and if it is present in an lens shaped structure, then you have to think of EDH, and it is an emergency situation where neurosurgery has to be brought in, and surgery has to be performed to evacuate this hematoma to save the patient. This is an SDH. Look that SDH usually crosses the usually crosses the suture line, and it can be very chronic also. Bleeding is under venous pressure, rupture of the bridging veins. Thus, hematoma can present quite slowly and grow to a larger size before patient develops symptoms. Elderly patient alcoholics are especially vulnerable to SDH, as the brain atrophy leads to stretching of the bridging veins and then subdural hematoma. So two types of edema are usually seen. These are cytotoxic edema and the vasogenic edema. Cytotoxic edema occurs mainly in the acute ischemia, what we have said earlier. Here in diffusion weighted image, this acute infarction causes a cytotoxic edema and represent as an bright structure, that is hyperdense lesion. Whenever the vasogenic edema is usually because of a tumor present in the brain, and it takes the structure of the gray white matter. And gray white matter differentiation usually seen when an vasogenic edema is present. See, all the structures are usually like the structures on the opposite side, but here the structure is not as like the structures on the opposite side. Whenever you see an normal structure like thing with hyperdense lesion, think of an vasogenic edema. But whenever the outlines are blurred, then think of an cytotoxic edema. So CT scans and MRIs are performed for knowing the bleeding and and the acute ischemia in the brain. But usually MRI and CT scan of the spine is done to know whether there is any bulging or the degenerating of the disc or the herniation of the disc, so that we can plan for surgeries. and also any fractures of the spine. So with this, we completed the basics of fundamentals of CT scan MRI. I hope that this was an informative class to all the nurses. With this, I'm presenting 5 MCQs. Um, can I proceed with the MCQs?
Yeah, you can proceed, Dr. Srinivas. Make it
Sir,
short. Okay.
sir, sir.
So go ahead.
So the first MCQ is the plane that divides the body into right and left half is medial sagittal plane, coronal plane, axial plane, or mid axillary plane. Somebody has said coronal plane, somebody has said medial sagittal plane. So it is medial sagittal plane. Very good. Some said it is mid axillary line. So the plane that divides the body into right and left is the median sagittal plane. A growing application of MRI is MRA, which stands for magnetic resonance amplification, magnetic resonance angiography, minimal radiography application, minimal research assistance. Very good. Most of them have said magnetic resonance angiography. Very good. The answer is magnetic resonance angiography. What is a major health concern with the MRI? Reaction to the applied drugs, extreme cold, radiation dose, localized burns due to metallic implants. Yeah, it is because of localized burns due to metallic implants. So select one of the following objects that you think would always be safe in the MRI suit. A wheelchair, a stretcher, scissors, none of the listed. A stretcher would be safe in MRI. Some are saying that it is B. No, the answer is D. So none of them are usually allowed into an MRI suit. So because these are metal structures, so metal structure can't be taken into MRI. So a wheelchair, a stretcher, and the scissors are not allowed into the MRI suit. Why is contrast used in CT scan? It is, yeah, it is B, to enhance a particular tissue. That's all.
Yeah, thank you, Dr. Srinivas.
Thank
It
you, sir.
was such an elaborative session on the imagology. So in the end, we will like to take some questions if anybody is having anything, but I think probably uh, for the critical care nursing level, so this is more than enough. He has gone into the depth of every corner. CT MRI, he touched the basic, he touched the pathology, then different pathology, different patterns, MRI patterns again. Still, we'll like to take some questions if anybody will having any doubt. So I think Dr. Srinivas, you have made everything crystal clear. So no one is having any question. So in that case, I think we can wind up the session.
Sir, I thank ISCCM for giving me this opportunity and Niranjan sir for giving me this opportunity. to represent myself at this level. Thank you all for giving me this opportunity.
Thank you, ICCM, to give us the opportunity from Apollo Hyderabad. Okay, thank you so much. Yeah,
Thank you,
we'll
sir.
log up.